Okay, now we're going to quickly review assessing a client's abilities and capabilities. So why do we do it? To see deficits in occupational performance. It helps establish a baseline, and it also provides a justification for OT services. So with range of motion, you can do a functional screening, or you can go ahead and use a goniometer and take detailed measurements. But some possible causes of limited range of motion include scar tissue, pain, and edema. So scar tissues that cross joints or run along tendons are particularly bad for range of motion. Pain will affect the person's willingness to move, and edema will also disrupt range of motion. So the functional screening goes through all your basic motions of your shoulder, elbows, and hands. So you have your shoulder flexion, extension, abduction, adduction, horizontal adduction and abduction, external and internal rotation, elbow flexion, extension, and so on. And so this is just a quick screening. Now the biomechanical approach to treatment. It's all about increasing range of motion through stretching. So you have your active stretching. So contraction of muscles are opposite to the direction of the limitation, that is the source of the force. And some active stretching techniques include gentle active stretching through slow repetitive isotonic contractions, and also using prolonged passive stretch position of the contracted tissue. So some ways to decrease edema are through elevation, cryotherapy, compression, massage, and using electrical currents. And all of that is dependent on the stage of the injury, the vascular status of the patient, and also the desired clinical effect. So strength. You can also measure a client's strength using manual muscle testing. And you could do a functional manual muscle test, which is just a quick run through that you use whenever you're doing your functional screening of range of motion, or you can go ahead and test every muscle individually. But the functional screen just kind of gives you an idea of what you need to further assess. So some ways that you can grade muscle strength, or like whenever you want to work on increasing a client's muscle strength, is by changing the intensity, the volume, the amount of rest in between exercises, the type and velocity of contraction, and also the frequency of the exercise that you're doing. So some ways to increase endurance. So endurance is the ability of a muscle to maintain performance over a sustained period of time. And some of these factors are you fatigue quicker, energy and oxygen storage within the muscle isn't optimal, and external factors that affect a client's endurance include room temperature, altitude, and also amount of recovery time during an activity. So some intervention methods include low intensity muscle contractions, large number of reps, and prolonged period of training to the point of muscle overload. So with endurance, you're not focusing on using heavy weights, but it's more the number than the amount, or the number of reps than the amount of weight or force applied onto a muscle. Okay, sensation is the body's ability to perceive stimuli. Choosing the assessment is largely influenced by whether it originates in the central nervous system or peripheral nervous system. CNS injury is more likely to have deficits in proprioception and stereognosis. PNS injury in touch pressure awareness and 2-point discrimination. So desensitization uses for clients with hypersensitivity, and the goal is to elicit habituation and improve overall function. So habituation is just decreasing the response following a repeated benign stimuli. So what is the somatosensory system? It handles sensory input from superficial and deep sources, so from your skin and also your musculoskeletal system. A dermatome is an area of skin supplied by one spinal dorsal root and its spinal nerve this illustration would be a good thing to study to kind of understand the somatosensory system. So dysfunction of the peripheral nervous system. So the typical order of sensory loss is light touch, cold, heat, then pain. This order is reversed for sensory recovery. Pain sensation and temperature awareness are both protective sensations. So with pain, use a sterilized safety pin and vary the amount of pressure to elicit a pain response. First you do this on the uninvolved side, then on the involved side, so you have a baseline for comparison. Correct response is intact protective sensation, incorrect is absent. So if temperature sensation is lacking, you're going to want to teach the client compensatory strategies. So with this, you apply test tubes or metal cylinders that are filled with either hot or cold fluid randomly to areas of the involved hand. You also do this on the uninvolved side, once again to get the baseline. So testing for touch sensation, you have your static 2-point discrimination and your moving 2-point discrimination. So 2-point discrimination, you're testing for receptor density, and it's good for mapping improvement following nerve repairment. So the closer the points are that a person can discriminate, the better. So 1 to 5 millimeters indicates normal static 2-point discrimination. 6 to 10 is fair, 11 to 15 millimeters is poor. For moving, 2 to 4 millimeters for ages 4 to 60 indicates normal, and 4 to 6 for 60 and above is normal also. So proprioception, it's awareness of joint position in space. So you're going to hold the lateral aspect of the elbow, wrist, or digit and move those into flexion or extension, and the client has to tell you whether their forearm is up or down, or their wrist is up or down, their hand, fingers, whatever you're testing. Stereognosis is you're using proprioceptive information and touch information to identify items with your vision occluded. It's like if you're reaching in your pocket and you need to get some change out and you know you need 75 cents. You're going to reach for either 3 quarters or any combination of quarters, nickels, and dimes to get there the quickest. Okay, so purpose of sensory evaluation, it helps assess the type and extent of sensory loss, determines impairment and functional limitation, provides directions for OT intervention, and also determines the need for education to prevent further injury during occupational functioning. So sensory perceptual skills, they're needed for self-maintenance, self-enhancement, and self-advancement roles. And their actions or behaviors a client uses to locate, identify, and respond to sensations, interpret, organize, and remember sensory events via sensations, like including visual, auditory, proprioceptive, tactile, olfactory, gustatory, and vestibular. Okay. Cortical injuries. So perception of fine touch and proprioception are going to be the most affected, followed by temperature sensation, and then pain sensibility will be the least affected. Recovery of pain and temperature perception usually precedes recovery of proprioception and light touch. Spinal cord injury. So damage to the central spinal cord equals bilateral loss of pain and temperature sensation below the level of the lesion. So depending on where the injury on the spinal cord happens, you're going to have different patterns of sensory dysfunction throughout the body. So it would be good to refer back to the illustration of the dermatomes to kind of help give you an idea. The gold standard for classifying for neurological classifications is the ASIA impairment scale. So that'd be something good to review. Peripheral nerve injuries can happen from compression, You can also have peripheral polyneuropathies, which are associated with like diabetes, alcoholism, AIDS. Full recovery of this is generally not expected. Just kind of review this about perception. So let's talk about some visual perceptual disorders. So we have agnosia, which is impairment in visual object recognition. Just ask a client to identify 5 common objects by sight. So if you're in a patient's room, just ask them, maybe identify the TV, a chair, the sink, the door, just whatever you see in the patient's room. Prosopagnosia is the inability to recognize and identify familiar faces. So you can intervene with this by providing face matching exercises, or you could adapt by providing pictures of family members and famous people with names, and then assist the clients to associate the family member's face with other unique characteristics or features. You can also have a little like a pocket photo album of familiar people, so that whenever someone new comes into the room, they can scroll through the album real quick, or maybe even on their phone, to put a face or to put a name to the face if they're having trouble. Color agnosia and anomia. Agnosia is just the inability to remember and recognize specific colors for common objects in the environment. Anomia is the inability to name the color of objects. So intervention, you're just going to want to provide the client with opportunities to recognize, identify, and name various colors of objects in their environment. Tactile perception, so astereognosis, again, inability to identify common objects perceived through their tactile perception. So again, with the coins here in pocket, just kind of review the rest of this. Right and left discrimination, dysfunction, so it's the inability to accurately use the concepts of right and left. So intervention, you can focus on assisting the client to practice reciting right and left while interacting with their body. Also, when you're standing to the left of a client, make sure to use the words, use your left arm, use your left hand, your left leg, look to your left, repeat left whenever you're on the left of their body. Same thing on the right, just to kind of try to increase the association that they make with that side being left or right. So behavioral aspects of perceptual dysfunction. A person unaware of perceptual deficits are a serious safety risk. Denial is common in early stages of recovery from stroke and TBI. And a person who has some degree of awareness of disability is often depressed initially. So some motor perception disorders, we have ideational apraxia, ideomotor, dressing apraxia, and constructional disorder. So ideational apraxia is the inability to use real objects appropriately. So I can tell you, here's a toothbrush, how do you use this? And then if the client starts brushing their hair with it, I mean, they kind of associated toothbrush with brushing something, but it's not the appropriate use for a toothbrush. Ideomotor is just the inability to carry out a motor act on verbal command or imitation. So if I illustrate or demonstrate how to brush my teeth, the person won't be able to repeat or return that demonstration of brushing their teeth. And addressing apraxia contributes to the inability to plan effective motor actions required during the complex perceptual task of dressing the upper or lower body.